morning, everyone. Thank you all for being here this bright, sunny morning. We had such a fun time last night. I want to let you know that I walked the runway. And yeah.
She should have.
And
won.
I didn't lose. Thank you, Lee. Thank you. First of all, let's thank our sponsors, because we all know without our sponsors, this event would not be happening. Our corporate sponsors are Rita. Thank you. Merck, Cone Health Foundation, ViiV, Janssen Pharmaceuticals, Pharma, Community Catalyst. So thank you all. Thank you.
Yeah. And we also have nonprofit sponsors. We have the Southern AIDS Coalition, UNC Care Cab, Latino Commission on AIDS, and the LGBTQ Center of Raleigh.
Whoop,
so
whoop.
Thank you all very much. Did you?
Oh yeah, how do I not thank the board? So thank you to the
played
North
this
Carolina
really well.
AIDS Action Network Board. You all are fantastic, and thank you for continuing to do what you do.
Wonderful. So we have the plenary is going to get started in a few minutes. I wanted to let folks know that we're gonna wrap it up. It's supposed to end at 10:15. We're actually going to end it at like 10:05 because we realize that some folks may need to check out. We have a kind of a staging room that's right by the front door called the Yorkmont Mount. So if folks do need to check out, just you can put your luggage in there. It's literally right down the hall, like it's the room where the COVID testing is happening. So you can put your luggage in there if you need to check out. I believe checkout is at 11.
It's at 11.
So that's why we're going to wrap up the first plenary just a little bit early. We have Matt Martin and Jeff on our board, Jeffrey, excuse me, and Rita on our Matt and Rita McDaniel from our team doing a plenary. So we are really excited about that. It's great information. And we're going to start there. Also, I need my readers. Okay. There are a few things going on out there that we want you to know about. Is Sarah Finley here? I can't see. Oh yeah, Sarah, do you want to come up, please? I want Sarah to tell you about what is going on here. She is doing some really cool healthcare power of attorney stuff for us for free. She's with the Charlotte Center for Legal Advocacy. So that table out there, there's actually 3 attorneys here. And if anyone needs a healthcare power of attorney, I'll let you tell them a little bit about what that means.
Okay, I'm project coordinator of the HIV Legal Project at Charlotte Center for Legal Advocacy, where we provide free legal assistance to persons living with HIV/AIDS.
Sorry. It's been a minute. So my name is Sarah Finley. I am an attorney and the coordinator of the HIV Legal Project at Charlotte Center for Legal Advocacy. We provide free legal assistance to persons living with HIV/AIDS when it comes to estate planning and breach of confidentiality. Today, regardless of diagnosis, we are providing free healthcare power of attorneys. There's 2 attorneys and 2 paralegals that would be here assisting. And a healthcare power of attorney allows you to name up to 3 people to make medical decisions for you only when you are not able to make them for yourselves. So with COVID and everything else and just life being in the way, if you're interested in having a free healthcare power of attorney, it only takes a couple of minutes. It's not a long document. Me and the other attorney, even the paralegals, will talk to you about the document, help you be able to name 2 or 3 people if you would like. You are not required. If you only have one person that you trust, who you know will make the same medical decisions for you, then that's sufficient. And it takes probably about 5 or 10 minutes. Thank you.
Awesome.
Remember, I hate to be morbid, but death has no age.
Oh boy.
Seriously.
Good morning.
So
everyone.
good morning. That'll be like the hashtag for the rest of the event.
Okay.
So
We're missing one person.
we're missing one person, but thank you to all the staff that's helping to pull this event off. And
Yeah.
we are going to, what'd you say?
Nothing.
Okay. We're going to move on to our next, to the plenary, right?
Yeah, we are. Matt, are you ready to go? Great. We'll get everybody together at the end when Christina's back in here. We have all our staff here. It's been fantastic. Thank you so much for pulling everything off. Y'all have been a fantastic team. We've got Dante Prayer in the front here, Deshae Coney, Matt Martin, Rita McDaniel, and myself, and Christina Adelike, who's currently at the registration. So I just want to give a huge shout out to the team.
Huge.
They're amazing. Thank you all for being here. And do you need this? Yeah. Oh, yeah, okay.
It on.
It is on.
Can y'all hear me? Oh, I hate microphones, but we're gonna just lean into it. And I will stay away from that one. Okay, great. Got it. I'll try and stand at the podium so that like I stay in the camera view, I guess. So good morning. So excited to have everybody here in person for the first time in a very long time. For folks who don't know me, my name is Matt Martin. I use he and they pronouns, and I serve as a grassroots advocacy manager with the North Carolina AIDS Action Network. And today I wanted to talk to us about some work that we've recently done here in North Carolina, specifically around PEP and expanding PEP services through, I realize I'm the only person up here, so I should take this off. PEP services through pharmacists here in North Carolina. So get in, loser, we're going to the pharmacy. Just a little bit of background. Of course, y'all know who we are, so we don't need to talk about that. Just to kind of give a background of HIV in North Carolina, which I think most of us probably know, but just to level the playing field. So approximately, we have about 38,400 folks in North Carolina who are living with HIV. And it's estimated that about 4,400 of those folks do not know their status. In 2019, approximately 1,383 new cases of HIV. This rate of new cases has remained pretty stagnant over the past 4 years, but I will say that there was a little bit of an increase in 2019, which is pretty alarming. I have a feeling we will likely see that. There might be a dip in 2020 just because folks are not getting tested as much with the pandemic. So we might see an increase in 2021. As of 2018, this is the most recent data we have. There are 3,771 active PrEP users in North Carolina. And specifically when it comes to PEP services and utilization, there's very little data as far as who is able to and who is actively accessing PEP services, which really kind of highlights the need for increased access and education throughout our state. So just to kind of, I think that the geography of our state is really important when we talk about PrEP and PEP services, especially for the work that we've recently done. So this is the most recent data of HIV prevalence in North Carolina. You can see the darkest areas, and I think, does this have a pointer? Nope, it's okay. I will stand over here. So the darkest areas are our I-85 corridor, which is like our, those are our kind of metropolitan areas. So we've got Raleigh, Durham, Chapel Hill, Greensboro, Winston-Salem, and Charlotte. So that's like the I-85 corridor. And then we have the I-95 corridor, which is in the eastern part. That's the more rural part of our state. It includes like Greenville, Fayetteville, and a lot of those rural counties where there's very few services available. And here's a picture of active PrEP services. Now, we don't have the information on PEP services, but I think we have a pretty good idea of like if there's PrEP services, it would probably be similar to PEP services. So you can see that we're doing pretty good when it comes to the I-85 corridor, which is the Raleigh area, Greensboro, Winston-Salem, Charlotte. But when you look at the eastern part of the state, there are huge gaps, especially in this area where there are no active PrEP providers and where folks are having to drive upwards of an hour just to access any kind of PrEP service. So I wanted to overlay this so you can really see, especially in the eastern part of the state where we have the darkest red, the highest prevalence of HIV, there in most of those areas, there are no PrEP providers. So you have to see how far folks have to drive in order to get any kind of PrEP services. As I mentioned, we don't have any information when it comes to PEP on this, but it's probably pretty similar. And I would say there are fewer PEP providers because it's a lot of people don't even know that PEP exists. And you ask them about it and they're like, I don't know what that is. So it shows the need for increased education on that. So our PEP access issues. Number one is stigma from physicians and other healthcare providers. I think we hear this a lot with PrEP and PEP, that a lot of folks will go into their physician and ask about PrEP or excuse me, not even be willing to ask about PrEP because their physicians don't talk about sex. They feel like it's really uncomfortable to talk about it, or they feel the stigma from their provider to even mention it. as we just looked, the location of healthcare facilities, particularly in the more rural parts of our state, it's really hard to find any kind of healthcare facility, especially HIV providers and infectious disease providers. When it comes to PEP access currently, there's a limit when it comes to when you can get it. So especially for nights and weekends, there's no opportunity to access those services except through the emergency room, especially with the 72-hour window for PEP. So if you think that you might have possibly been exposed to HIV, are looking to get on PEP, you have 72 hours within that time frame of exposure to get on it. And then just general, very little public knowledge of this prevention strategy. We hear about PrEP all the time. PrEP is in our ETE plan for the entire US, but PEP is not included in that. So there's very little education and very little information about this. Okay, so why do we think that pharmacists are a good place to start when it comes to PEP services? So in particular, in rural Eastern and Western North Carolina, as we mentioned, there are these really large deserts where there are very few providers, especially for HIV services in general. One of the bill sponsors of what we're going to be chatting about, Senator Bergen, this is a quote that he said, and I think this is really alarming when we think about it in our state. So we have 100 counties. In North Carolina, there are 5 counties without a family physician, 20 without a pediatrician, 26 without an OBGYN, and 30 without a psychiatrist. And so in those communities, we see that pharmacists are often serving as the main source of healthcare for many folks who are living in the rural areas of the state. So a lot of folks are using the pharmacist as kind of their only contact with the health system. The 72-hour window with starting a PEP regimen makes seeking services outside of that traditional healthcare 9 to 5 when folks go to the doctor's office really difficult. And so it often leaves emergency room trips as your only option, which especially for under and uninsured folks we know is just out of the question because of the cost. And then this is just a really natural fit for our health system and providers, especially I think during the pandemic when appointments are so hard to come by when it comes to healthcare. We know that doctors' offices are overwhelmed and the healthcare system in general is overwhelmed, but I think a lot of folks have had to lean on pharmacists, and that when we think about like COVID testing and COVID vaccines, the pharmacist is actively there in our community at being able to administer those services. So it just seems like a really logical fit in our health system that's already overburdened. So we have recently started seeing some policies come up across the country around pharmacist administered PrEP and PEP. So wanted to kind of highlight a couple of those. The first state that did this in 2017 was New York, and they allowed for pharmacists to prescribe PEP through a PEP starter pack. So this happened in the New York City Department of Health and excuse me, Mental Hygiene. And they did a survey and decided to push this forward because it seemed like a real need. So the Board of Regents issued a standing order that went into effect in March 2017. So this is a while back. And it's a little bit limited. It prescribes an initial 7-day supply of PEP. And then from there, the pharmacist refers folks to a provider for that continued, I guess, 21 days post that. So that was the first kind of like rule change that happened in the state of New York. And then we started seeing some legislative policy changes that happened as more of a statewide coalition. The first one that kind of set the scene was in California with Senate Bill 159. This was kind of put in place by APLA Health, which is a healthcare provider for folks who are living with HIV and LGBTQ folks. And the California Pharmacists Association, they were really big drivers of this legislation. So they had a bill that was very broad, and as far as anybody can go to the pharmacist at any time and get PrEP and PEP. But there was some real concern from the medical societies, especially. So it limits the frequency that folks can use this. It limits the amount of PrEP that folks can get in the first kind of go round, and it limits the amount of time that folks can do it. So they can only get a 30 to 60-day supply once every 2 years. So not perfect, but it's still a really good starting place. And then pharmacists can also prescribe the full 28-day supply of PEP. Another important thing is it also removed insurance pre-authorization for both PrEP and PEP, which we know is vital. So that happened, that happened in 2019, October 2019, and became implemented in January. And we all can imagine what happened. like 2 months later. So this has been a very slow rollout. And I think they are still in the process of kind of getting this going. And then in Colorado, they introduced House Bill 20-1061, introduced in January of last year and became law in July of last year, which I think is really important with the pandemic. And this is very similar to California, but I think it's a little bit broader and doesn't have as many restrictions as far as like frequency and amount of time that folks can be prescribed through the pharmacist. And it also removes the insurance pre-authorization, which is huge. And here's a quick quote from the senator who was one of the sponsors of the Colorado bill, which I think is really important when we think about the pandemic and the need for this. So 14,000 Coloradans live with HIV today. That's 14,000 people with compromised immune systems who have increased vulnerability to viruses like COVID-19. Both HIV and COVID-19 disproportionately impact communities of color, which is why this bill is critical to expanding access to preventative medications for those who need it most. Again, healthcare systems are overwhelmed right now, and pharmacists are where folks are able to access at different parts of the day outside of the typical 9 to 5. So this is a really important move to have folks access their preventative medications. All right, implementation has been kind of slow. They are doing this through a board-approved training program. It's an opt-in program where pharmacists can opt into this, get the training, understand how to administer and read an HIV test, and then kind of go from there. Right now, they're mostly spreading awareness because it is so new, and I think the pandemic kind of shifted everything in our health system to where this was kind of put on the back burner for a little bit. But we have spoken with especially the folks in California, and I think they're starting to slowly roll it out. So currently, right now, they're mostly doing awareness through pharmacists to get them to enroll in the program. Now, a failed bill, unfortunately, was in Oregon with House Bill 4116. It was also introduced in January of last year, but there were some real public some real concerns from the medical society specific to PrEP. And I think it was because the bill text language was too vague. It was a little too broad in the scope of practice. And there was some concern about the removing of the pre-authorization, which seems counterintuitive to me, but I digress. And ultimately the bill died in 2020 of their legislative session. But there is, I think, hope from the same sponsor to re-up this bill and have some modifications so that they think they'll have more success. And then most recently this year in Virginia, they passed a kind of a broader pharmacist bill that had 9 different medications and groups of drug services that folks can administer or can access through pharmacists. And that includes both PrEP and PEP. Theirs is pretty broad in the understanding, so I'm assuming that it's probably going to go to the Board of Pharmacy to decide exactly what the rules and stipulations are. But as of now, it's pretty broad. This was introduced in January, passed in February, and was signed into law in March. So this one happened really quickly this year. All right, so let's talk about what we did here in North Carolina. It's a little bit different than them. So we started having internal dialogue with staff in 2019. I think a couple of our staff folks went to the NMAC Biomedical Summit, listened to some presentations about pharmacy distributed PrEP and PEP. We were like, this seems like something that could really happen in North Carolina and would be a really logical fit. So we started having conversations with the North Carolina Medical Society, the Academy of Family Physicians, and the Association of Pharmacists. I will be transparent that the Medical Society and the Academy of Family Physicians did give us some pushback when we started talking about this because they felt like we were encroaching on what doctors were able to do. But we will talk more about that later. And the Association of Pharmacists was really excited about this, and we found out through them that they were going to be working on something similar to this anyway. So most of this initial conversation happened pre-pandemic. So, you know, things shaped up a little bit differently as we moved into 2020. To get this idea out into the public, we did write a couple of media pieces. I wrote something with Dr. McKellar. Lee and Daphne Ward with Southern AIDS Coalition submitted something just to kind of get this out into the environment so that folks in the communities would understand kind of what this policy change was like. And then we worked with a Master's of Public Policy student at Duke who was doing a program through Duke to sit on our board. And she created an incredible memo outlining all of the different policies that were happening across the state and kind of best practices that has now actually been used kind of nationally, and NASDAQ has picked up and distributed to kind of hopefully get this policy moving throughout the country. Are we? Oh, oh. Next slide, please. I think my clicker has died. There we go. Teamwork makes the dream work. Okay, so after initial conversations, we realized that we really wanted to stay in touch with the Association of Pharmacists. They seemed really excited about the conversations that we had, and we found out that they were planning on introducing several pieces of legislation that were kind of similar to what Virginia did, with a full slew of drugs and devices that were going to be able to be administered by pharmacists. So we were like, this seems like a really logical place for us to work with them. So it was included in this full thing, and initially we knew that we wanted to include both PrEP and PEP. So once we knew this was going to happen, we partnered with our friends at the Southern AIDS Coalition, who have been incredible, to help advance this policy, and especially make sure that as we're moving this forward, that it's equitable and is going to hit the communities who need it the most. Next slide, please. So here's our kind of advocacy strategy when we started thinking about this type of policy. So prior to moving any type of legislation, having any type of meetings with any representatives, we started with a virtual petition that kind of outlined the type of policy that we were hoping to pass. We had over 600 folks throughout North Carolina signed on that petition, which is great. And we gave that list of signatures to Department of Health and Human Services Secretary Cohen on World AIDS Day, when Lee had a conversation with her via Facebook Live. We also met with the representative from APLA in California, just to talk about how they went about this process, what were their strategies to make sure that we weren't reinventing the wheel, and kind of figure out what their lessons learned were. So any mistakes that we could kind of hopefully avoid. And then we reached out to House Health Chair Donna White, who's a House Republican. She's also a former communicable disease nurse and worked specifically with folks who are living with HIV. And she kind of steered us in the right way of folks who are planning on working on some Pharmacist Bill. So that was Representative Sasser, who was a Republican, and Representative Bergen, who's also a Republican. So we established and cultivated those relationships with both members, and knew that we had to keep talking about this and making sure that the PEP and PrEP piece were included in the final legislation that was introduced. And then we also did some public education opportunities. We did that through our community here. We did it through the Association of Pharmacists, and we presented at the Biomedical Summit this past year. Next slide, please. So, continued advocacy strategy. Once the legislation was introduced, we attended all of the hearings and listening sessions, the subcommittee meetings, and everything, and continued to meet with the members of both the House and Health Senate just to make sure that this was advanced and it was staying front of their mind. We hosted community trainings with North Carolina advocates to make sure that they understood the structure of the bill and that would know how to speak to the representatives, because this was something that we knew that we wanted to talk about at our advocacy day, HIV Speaks on Jones Street. So wanted to make sure that folks in the community knew what was going on, had input as to what was going on. And as I mentioned, we did have a large focus of this on HIV Speaks on Jones Street. And then we also worked with several providers, some specific med docs who were supportive of this, and created a sign-on letter of, I think, 8 different docs from across the state saying like, hey, this is actually a really good idea. We should make sure that this happens. Next slide. So when it comes to the legislation that was introduced, there were a few surprises, which was actually good surprises. So initially 3 bills were introduced. So we have a Senate Bill 575 and House Bill 512. Both of these were called Pharmacists and Improve Public Health Needs. They're the exact same language, but Representative Sasser and Senator Bergen wanted to introduce both a House and Senate bill. That way it had a better chance of really moving forward in the General Assembly. And then we found out that Representative Sasser kind of snuck in a bill that we didn't know was going to happen called House Bill 691. And this was specifically around PrEP and PEP. We had no idea this was going to happen, but we were like, oh, wow, that's really great. So he did that as a backup in case the other ones had no movement. So we were very surprised about that. That was not something we chatted about with him, but he seemed excited about it. So we were really excited. So both of the Senate Bill 575 and House Bill 512 were in the form of Virginia with a full list of medications and devices that pharmacists could just prescribe. And then upon initial conversation with the bill sponsors, with the Academy or Association of Pharmacists, we realized that the Senate bill was probably the one that was going to move the fastest. And it was introduced in Senate Health and then actually started moving really quickly. We were very surprised with how quickly it was moving. There were some modifications, some things that we didn't really hope to happen, but happened anyway. PrEP was taken off the table, but PEP was included. There was a lot of pushback from the medical society around the PrEP piece, and they were pretty relentless in not having that included, I think because of the tests and the labs and the recurring 3-month thing that happens with PrEP. So it was removed from the bill language. We were disappointed by it, but I think for us, PEP seemed like the most important part with the pharmacist piece because of the emergency nature of it with the 72-hour window. So it moved forward through all the committees and then went to the Senate floor for a vote and actually passed unanimously, which we were very surprised and excited about. Next slide. Now, it seemed to be moving, but the sponsors were a little bit afraid that the Senate bill was going to get hung up in the House Health Committee and not move forward. So what they decided to do was take that language from the bill and add it to an amendment as an amendment to a House bill, which was House Bill 96 that was already introduced and passed in the House that was now in Senate Health. So Senate Health then had kind of the power to move it faster and faster. So this was a House bill that was around pharmacists as well. It was around administering injectables. And so they kind of added this in on the end. It moved, once it was added as an amendment, it moved so fast. It went into House Health, passed really quickly, then had like 2 other committee hearings just to make sure before it went to the Senate floor. We went expecting to have to give comment, and both of those meetings were less than 5 minutes. And they were like, y'all go with this? Cool, let's move it forward, which was awesome. So then it went to the Senate floor for a vote, again, passed unanimously, which we were excited about, and then had overwhelming support in the House upon concurrence with 106 to 5. So only 5 folks who were opposed to it. There was some pushback last minute when it went to the House because there was some language that was added to the bill specifically around COVID vaccines for minors and requiring parental consent. This was prior to FDA approval. And luckily, as literally like the day after this was signed into law, the FDA approved the Pfizer vaccine. So that little add-on to the bill was like null and void, which was great. But those 5 that voted against it were particularly upset by the provision around COVID vaccines. And so it passed and was signed into law on August 20th of this year by Governor Cooper. So what's next? What does this mean for us? Next slide. This means that we have to now keep track of this. We know that it's a law. We're excited that it's going to happen. But when it comes to implementation, we have to make sure that it's going to hit the communities who need it most. So from now, it goes to a rule change process, or excuse me, to a rule process by the pharmacy board. The Association of Pharmacists is creating some lists of like recommendations as to here's how we think this needs to be done, how it needs to be rolled out, and how pharmacists need to do this. And we're working with them on that. But ultimately, it will be up to the board, but we will make sure that we are there at the table to advocate for the community and make sure that it's successful for folks. So what are the key takeaways when it comes to this type of legislation? First, you want to start with what and who you know. So figure out who's actively already involved in this type of work, who's interested in being involved in this work, and make sure that you're not reinventing the wheel, and really cultivate those relationships both organizationally and legislatively, and also within your community. I think this is really important, is to have realistic expectations. With timing and movement, of course, we know that bills and laws move really slowly in the General Assembly. We were super lucky with this, that it moved so quickly. We expected this to be like a 2 or 3 year long process, and it wound up being like a 6-month process. But ultimately, you have to be realistic in knowing that it's going to move probably pretty slowly, and you're going to have modifications and compromise, which are things that you don't want to have happen. We wish that PrEP was included. I think we are going to continue to fight for more PrEP access and hopefully have this included in the next couple of years, but that's where it is right now. This is really important, is to have bipartisan legislative champions, especially here in southern states, because we understand that, you know, House Republicans and Senate Republicans kind of have the upper hand when it comes to the South. So it's really important to create some relational advocacy with those House and Senate Republicans and Democrats to advance progressive and impactful legislation. So really cultivate those relationships. Community education, involvement, and leadership should always be front and center in any kind of policy that you're driving, especially with the HIV community. We know about MIPA, meaningful involvement of people living with HIV and AIDS. And that's how we want to approach all of our policy to make sure that the folks who are going to be most impacted are at the table leading the conversation. And just because the bill is law does not mean the fight is over. So now we have to make sure that the Pharmacist Board really advances it in a way that's going to be equitable for folks throughout our state. And finally, virtual advocacy is like really hard. So if you can avoid doing things virtually and wait until the pandemic is over and can do it in person, I would highly recommend it. And that is how I felt most of 2021. And next slide. Okay, so that's kind of how we did it and what's happening here in North Carolina. We have worked with our friends at Duke who did a survey of South Carolina, particularly with pharmacists, to really figure out like, what do the pharmacists feel about this? How do they think they would do with PrEP and PEP services? So they surveyed a lot of folks who are pharmacists throughout South Carolina. And I asked him to send us a little video kind of talking about their survey. So just wanted to play that for y'all.
Hey everyone, I'm Charlie Burns, an infectious disease fellow at Duke University. Thanks for letting us present virtually about our project, Perceptions of South Carolina Pharmacists for Providing HIV Pre-Exposure Prophylaxis. I have no disclosures. And so briefly, we're going to talk about PrEP in the South, so HIV Pre-Exposure Prophylaxis, why pharmacies are a potential access point for PrEP, and then South Carolina pharmacists' perceptions on providing PrEP. So as we all know, HIV is still a big problem in the United States, with the United States Department of Health and Human Services launching the Ending the HIV Epidemic, with a goal of 75% reductions in new HIV infections by 2025 and at least a 90% reduction by 2030. This is especially important in the United States South, which comprises over half of new HIV infections nationally. And you can see the difference in rates there based on the darkness, how dark the red values are. And so one way to combat the spread of HIV is through HIV pre-exposure prophylaxis. And that is given as a once daily pill. And when taken correctly, it is highly effective at preventing the acquisition of HIV. However, the South, while being one of the largest areas of HIV transmission, is actually the lowest area of PrEP use. With South Carolina, one of the key states highlighted by the Ending the HIV Epidemic initiative due to the disproportionate rates of HIV in rural regions. In 2018, South Carolina only had 11.7% of eligible persons actually receiving PrEP care. And one of the potential barriers is limited access points to PrEP, where it's usually only offered at academic clinics, public health departments, or other STI, sexually transmitted infection care sites. Other locations have had a lot of success with alternative access points to PrEP. And so these have been feasible in things such as one-step PrEP in Seattle, which is a single encounter for STI and PrEP care and lab testing, telehealth PrEP in Iowa, and pharmacist-driven PrEP in California. But really the limitations on what strategies you can use are based on state law as to who can provide PrEP and how it can be distributed. So our hypothesis was that focused on pharmacies, and our hypothesis was that by expanding PrEP services to pharmacies, we can increase PrEP access and use by persons at risk for HIV acquisition throughout South Carolina. However, the first step is really to determine whether this is feasible and acceptable by pharmacists and what needs they need for this to happen, especially for those practicing in the state. And again, this was really driven on success other states have had with providing, with allowing pharmacists to provide PrEP, such as California, as we just mentioned. And there's also a big interest in this among pharmacists within their own literature. But again, why pharmacies for PrEP? So the CDC estimates that 70% of rural residents live within 15 miles of a pharmacy, and 90% of urban residents live within 2 miles of a pharmacy. So they're really community facing, easily accessible, and well-known by patients, and patients are comfortable with them. Also, there's already pharmacist-centered PrEP education and drive for this within pharmacy literature. So what we did to learn more about pharmacists' knowledge, attitudes, and perceptions towards PrEP is develop a survey in collaboration with the Duke Initiative on Survey Methodology. And we distributed this survey through the University of South Carolina Kennedy School of Pharmacy professional listserv. And through them, we were able to reach about 2,400 unique emails. And from there, again, we were really looking at pharmacists' knowledge, attitudes, and perceptions toward PrEP. And our main findings were that respondents viewed PrEP as both effective and beneficial for their patients. They felt that pharmacies were an appropriate location to prescribe PrEP, and respondents were both ready and willing to prescribe PrEP if allowed. But now drilling down on those findings in a little bit more detail, we were able to get 150 responses, which is about what you would expect from an electronically distributed survey such as this. And the key takeaway here is that we had a great distribution of pharmacists from different practice locations, from rural, small towns, suburban, urban locations across the state. And we also had pharmacists from a variety of different practice types. So anything from academic, community, hospital-based, independent, retail, specialty, and unknown. The other important fact here is that there was a wide range of practice experience with a mean of 17 years, but a range from 1 to 50 years. So a lot of experience. And as far as the results go, most pharmacists, 67%, thought that PrEP was effective. And even more, 74% thought that pharmacists providing PrEP would be beneficial for their patients. Again, around about the same amount, 72% thought that pharmacies were an appropriate place to prescribe PrEP for patients. When asked about readiness and willingness, about 60% said they were ready now, at least somewhat ready now to prescribe PrEP. And 86%, so most of the respondents, were willing to prescribe PrEP if they were able to. And again, you can see the number of respondents change for each question, as we didn't require participants to answer every question. They can skip any question they wanted. And we also asked about some of the barriers pharmacists saw to prescribing PrEP within the pharmacy setting. The biggest barrier was costs and patient insurance status concerns. And this one can be overcome with various patient assistance programs that exist to help patients afford this medication. And again, pharmacists are typically very familiar with medication assistance programs and navigating that type of system. The other issue is a lack of knowledge and comfort with PrEP, but again, there are educational programs through the CDC and within the pharmacy literature that can help educate and increase knowledge and comfort for PrEP for pharmacists. The third biggest barrier is, again, lack of time, and I think this will vary based on the pharmacy setting that the pharmacist is practicing in. But the lowest barrier really was PrEP side effect concerns, and I think this is because, again, a lot of the pharmacists we surveyed actually dispense antiretrovirals, so they're already familiar with these medications and the potential side effects and how to mitigate those. So the overall goal would be, again, if we can get pharmacist-driven PrEP, which is something I think we can do by increasing knowledge and comfort through educational initiatives, we can increase PrEP access throughout the state. And again, pharmacists are easily accessible and can cast a large net. And again, as the CDC had estimated that most people live within a short distance from a local pharmacy. And from there, we can increase PrEP use, but at first we'll need to figure out how to bridge the gap between willingness and readiness to prescribe PrEP. And ultimately, if we can increase PrEP use, we can decrease HIV transmission, with the final barrier being reimbursement strategies to help pay for these services in pharmacists' time, which need to be addressed by the state. And so this project had been funded by the Duke University Center for AIDS Research, and I had received training grant through an NIH T32 grant. And our whole team here is made up of persons from both Duke University, the Initiative of Survey Methodology, and the University of South Carolina. And with that, I thank you for your time.
Am I back on? Great. Sweet. Okay. So I think, as you can see, this is a really logical place to move forward when it comes to policy for HIV prevention services. I think we're going to start seeing this a lot more across the country, and hopefully here in our state, we'll be able to advance this type of policy even further to include PrEP services for our folks. And I think it's probably going to change too, as we see new forms of PrEP, as we see injectables, long-lasting injectables. I think it could really change. And so I'm excited for that type of policy. But that is only one piece of our puzzle when it comes to advancing access for PrEP and PEP and general HIV prevention methods. So I wanted us to have a quick community conversation with folks who are working in the community around what we're missing when it comes to HIV prevention services. So I'm joined by some of my very favorite people in the world. So let's start with number one, tell us who you are, what your work is, and what's your involvement when it comes to HIV prevention.
Everyone,
and y'all can start whoever wants, whenever you want.
Hi, my name is Rita McDaniel. I work for North Carolina AIDS Action Network as their Durham community organizer.
And Rita, what's your involvement with HIV prevention?
Oh, gosh. My involvement is to get the word out, to educate. And my passion right now is females in PrEP. So that's my involvement.
Good morning. My name is Jeff Edwards Knight, and I work for Mecklenburg County Public Health here in Charlotte. And I'm also on the board of NCAN. And at the health department, I am a program health supervisor, and I supervise the county's HIV STD community testing and outreach program, as well as I'm the county lead for the county PrEP initiative, in which the county pays for PrEP office visits and labs for individuals who are uninsured and underinsured. And also I supervise the state's PrEP initiative for the TGA, which is the transitional grant area, which includes 5 counties in North Carolina: Mecklenburg, Gaston, Cabarrus, Anson, and Union. And I'm also someone who's been living with HIV for now 35 years.
Awesome. So when we look at our communities and the services that are currently available, I think y'all working on the ground see this every single day. What are we missing? What is our blind spot when it comes to prevention services?
I think one of the areas we're missing, our PrEP initiative, and at least in Mecklenburg County, has done pretty well. But I think what we're missing is we're not reaching the rural areas, as has been mentioned several times this morning. My state PrEP coordinator has been working in Anson County, Union County, trying to get a provider to prescribe PrEP. And at the point, we're giving a contracts where we're going to pay for the office visits and the lab work, but they are just flat out refusing. Not because, some say it's because they don't have adequate staffing. Others, like the health department in Anson County, just flat out refuses and just says no discussion. They're just not going to do it, but they will refer people to Charlotte, but they don't want to have any part of PrEP or having a PrEP provider. And Union County, we're trying to work with some individuals in Union County. So I think it's really the rural areas right now that we're missing. And also I would have to say, we're missing African-American heterosexual men. And I think part of that is because one, just not recognizing the benefit of PrEP. And I could go on and on, but I know we're limited time and Rita needs to talk as well.
I think we're missing the mark with not only in rural counties, but places like Durham, Raleigh, Chapel Hill. There's a lack of education and there's a lack of communication. We don't talk about PEP or PrEP. And PEP is very rarely talked about. And so it's like, to end this epidemic, we have to start from the beginning. You have to be able to talk about sex and the different ways to have sex. And then you have to talk about ways to have sex safely. And if you make a mistake, then you have to have the wisdom and knowledge to know that there are places that you can go, mainly to the emergency room right now, I believe it is, to get PEP. And that's a big cost on our county's government, having that expense for emergency rooms. And so if we follow these steps, then and educate people, like the need is to be educated. I don't have a profession in this. I'm solely the groundwork. And I work strictly with the community. So my aspect of it is different from someone that sits behind the desk and downput to those that do it, because I know they have an important work to do also. But just by me working in the fields with Matt, going to prides and things like that, and asking, especially women, what do you know about PEP and PrEP? And they say nothing. And that bothers me, because especially women of color, the rates of HIV are going up. So we got to back up and figure out where we need to start at. And I think the start comes from education and talking about it. And it's like, how do we all get here? By having sex. You know, someone had to have sex in order to create us. So we need to keep this conversation going and not let it be such taboo.
Yeah, for sure. And I know, Rita, one of the things that I know you and I have talked about a lot is when it comes to the educational materials and the outreach materials that we have. Can you talk a little bit about what you think is missing from those? Because I know you have thoughts on those, because we talk about it a lot.
I hope no one's in here from Gilead, but I hate that the advertisement that they display. If I'm at a convention and I'm walking by the table and there's information on the tables about Descovia and Truvada PrEP, and I don't see a female on that front cover, I'm not going to think that it's for me. And so I'm going to walk by, but it may be something that I really need. But if it's not out there, you know, to have some women on there, some cisgender women, because we need it too. And if you don't advertise it for me, and it's always a gay man on the front cover, a gay white man on the front cover, or a gay Black couple on the cover, because, you know, at one point, that's where the monies was going, was, oh, we got to get all these SMMs into getting PrEP, but you're forgetting about the rest of the population. I don't like the way that Gilead is advertising it. Please forgive me, Gilead. I love you guys. But I wish that they would put more women on the front covers and not have to flip through their brochures to find a female in their literature. And I don't know how we can change that, but in order for us to build up our women with PrEP, we're going to have to do some more advertising. We're going to have to get more women talking about this. I noticed from talking to women that, you know, their healthcare provider doesn't talk about it. Their OBGYN doctor doesn't talk about it. We need to have this serious conversation. And maybe it's a good thing that the pharmacists are getting PrEP now, because maybe that's a place that we can have a conversation about PrEP, and especially for women.
I think it's part of it. Is also dealing when it comes to dealing with people of color, particularly African-American men and women, is the medical mistrust part that's still there. African-American men are the ones who are less likely to go to a doctor or less likely to seek out healthcare, and just that getting that information and that knowledge, even when we were in our testing programs and we're talking to folks about PrEP, folks will talk about the number, as you mentioned, the number of sex partners they've had. But when you go to talk about PrEP, well, no, that's not something I need. And no, I don't trust taking that. Isn't that for those gay folks? That's not something that I'd be interested in. That's not something for me. How does that relate to me. And even when you try to explain to them this, we still have those same issues. So it's some of that medical mistrust, some of that education. And then again, when you're looking at, as Rita said, some of the advertisements, you don't see people who look like you, so you don't think it has anything to do with you. So I think those are some of the things that we need to work on.
Yep, for sure. And I think we're running close on time, so I'm going to ask my final question and then give us just a second for one or two questions if anybody from the audience has it. So what is your dream scenario of what prevention services would look like? If you could wake up tomorrow and anything that you wanted when it came to prevention services, what would that look like? I know that's a big, bold question.
I'm going to say for me, there wouldn't be any stigma attached to HIV testing, STI testing, or PrEP services. It would be just standard testing services, just like any other service that is medical service that's provided to you. And it wouldn't be all the stigma associated with it.
I think I would wake up and there would be no more HIV. And that's because of you could go to your local pharmacies and PrEP is prescribed. You're having that honest conversation one day sitting at lunch and you're talking about women sitting there talking about being on PrEP and how it's doing, like back in the day when you were on birth control and you have that conversation and everybody wants to get on birth control because that was the thing that was keeping them healthy. And we wouldn't be having these conversations now. And it's sad that here we are at 2021, we're still having these conversations. And stigma plays a real role. And how do we get over that? Excuse me. But it's so many people living with HIV from different backgrounds, whether it's race, economics, education, that we shouldn't even be having these conversations. And we shouldn't be afraid to say publicly, hey, I live with HIV. But there's so many people that in their own families, they can't even tell that story. And it should not be that way. It's just like having a common cold. And we should be able to say, hey, I'm not feeling well today. My HIV is bothering me, or my viral load is up a little bit because I'm taking this medication or taking that medication. But I'm not contagious, but so that's what my dream world would look like.
Awesome. No need to apologize. Okay, we've got just a couple minutes. I know that Deshay had a question in the chat, so I'm gonna, or someone on the video had a question. So, okay, perfect. Carissa, the floor is yours as soon as you are unmuted.
Can you guys hear me?
Yes.
Okay, thank you for the opportunity. My name is Carissa, and I am a harm reduction outreach worker in Robeson County, which is in the red. And I have gone to the health department personally 5 times, spoken to the director of education, asked for, because I work with people with IV use in sex work. And their health isn't good. And I have asked for brochures to distribute. The people that I work with, most of them do not even know that the health department offers free testing for STIs, HIV. The sex workers are paid more money if they don't use protection. And when I ask for condoms, they provide 2 condoms per person per visit. And I am in I myself am in recovery. And it's like the stigma that we're talking about is real. And I know that we're talking about PrEP, but when people don't know their status, PrEP isn't an option. And it infuriates me. I've tried to advocate. I've tried to be the squeaky wheel. I've asked multiple people outside of the director. I've looked through the brochures that are available and posted, and there is absolutely nothing. And I'm new to learning about HIV, AIDS, PrEP. So I want to be, I don't want to give out misinformation, but I want to make sure people have, availability to health care and aren't stigmatized. And it's like they don't care. And that makes me want to lose my mind. And so do you guys have any suggestions? Because I'm the only person, I don't have a team in my area. There's power in numbers, and I don't know what to do. But their answer to me is unacceptable. Thank you for your time.
Yeah, absolutely. So, I mean, I think there are definitely resources that we can get you. I will say the best thing to do is to reach out to me via email, which Deshay can drop in the chat, and we can chat and figure out some ways to collaborate together and hopefully make some change in your community. We appreciate the work that you're doing, though.
Thank you so much.
Awesome. So I know we are at 10:07. We were going to try and wrap by 10:05. So wanted to give folks a couple of minutes to go and unpack if you need to. The next sessions start at 10:30. So here in the Queen City Ballroom, we're going to have hepatitis ABCs. And then option 2 is white feminism harms us all. That's in the Woodlawn room, which is going to be right beside the registration table. There's a little alcove right down there. So that's where that is. That will start at 10:30. So we've got about 25 minutes. So if you need to go pack up and check out, feel free to do that. Grab some coffee. There's still some breakfast left over. Thank you all for listening to me ramble on for an hour. And Christina has an announcement.
Wow, let's give a round of applause. So I'm so glad y'all made it after last night. I'm impressed. I feel like we all deserve a medal for that. But I just wanted to kind of talk through some of the sessions that you'll be experiencing today. As Matt mentioned, there'll be the White Feminism Harms Us All session, which has been a workshop that has been happening locally in Charlotte. A lot of different organizations have been wanting to hear this. It's about the reproductive justice movement, which of course, like in this time and age with Texas and North Carolina, every legislative session, there's always abortion attacks. But there are folks who do this work and organize in this space